I'd like to welcome you to the second webinar in Arthritis and Osteoporosis Victoria's 2015 Musculoskeletal Health webinar series. Tonight's webinar is titled Understanding Complex Regional Pain Syndrome. Before introducing our presenters for tonight, however, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time that will be read by the webinar organiser at Redback Conferencing. If you are listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, can I remind you that whilst our presenters will answer questions after the completion of both presentations, you can actually type questions for them at any time. Can I suggest you don't leave your questions to the last minute, as we will aim to finish strictly at 8 p.m. Eastern Standard Time. I would be very grateful if all participants could take a moment at the end of the webinar to complete the exit survey, as this information will greatly assist us in evaluating this webinar and planning future activities. I would now like to introduce our presenters for tonight. Dr Flavia Di Pietro qualified as a physiotherapist in 2008 and has a strong interest in persistent pain. Her PhD, awarded in May 2014 by the University of New South Wales, investigated the role of the brain in complex regional pain syndrome using MRI. Flavia holds an NHMRC CJ Martin Early Career Fellowship and is based at the University of Sydney. Flavia's co-presenter for this evening is Dr Anne Daly. Anne has over 20 years' experience as a musculoskeletal physiotherapist and has also had a long-term interest in persistent pain and specifically complex regional pain syndrome. Anne has co-authored 3 systematic reviews on CRPS and has presented at both international and national conferences. Anne works as a clinician within the Interdisciplinary Austin Health Pain Service and as a physiotherapy and pain management advisor to WorkSafe Victoria and the Transport Accident Commission. Without further ado, I'll hand proceedings over to Flavia. Thanks very much, Flavia.
Thanks, Jen. It's Anne here. I'm going to start off.
Sorry, yes, Anne, thank you.
No problem. Welcome, everybody, and thank you for the opportunity to speak. Flavia and I have got a lot to say tonight, so we're going to try and move through quite quickly. I understand that you can access the slides at the end of the night, and I've actually included some extra slides with additional information for you. So first of all, I'm going to give you a little bit of an introduction into what is CRPS. And then Flavia is going to come on and speak for longer regarding neuro-imaging. And then I'm going to speak for again, a longer period of time regarding the management of CRPS. And hopefully at the end we'll have some time for questions. So first of all, there is a definition for CRPS. It's now just over 20 years old when the title CRPS became accepted for what used to be called reflex sympathetic dystrophy, shoulder-hand syndrome, and a whole lot of other conditions. So we have this official definition that you can see there before you, but I'm just going to go on quickly towards the definition, the revised diagnostic criteria. And it's really important when you're seeing people that you suspect may have complex regional pain syndrome that you use these diagnostic criteria quite stringently to make sure that you are actually diagnosing CRPS when it is present and not just making an assumption that they have CRPS because they have a complex condition to manage. So these 4 criteria, firstly that there's continuing pain which seems to be disproportionate to anything that set pain off in the first instance. And each person must be able to report that they've got at least one symptom in 3 of the following categories. There's also a slight tweak on this when we use these diagnostic criteria for research purposes, and that's when we want someone to have at least one symptom in all 4 of the criteria categories. So these categories are sensory, vasomotor, pseudomotor or edema, and motor or trophic, and I'll speak a little bit more about that in a moment. But as well as having symptoms, patients must also display at least one sign in 2 or more of those same categories. So that means you've got to be able to see it at the point in time when you're assessing the patient. And the fourth criteria is really that there's no other diagnosis that better explains the signs and symptoms. This is quite a difficult thing in clinical practice, and I think the more experienced you become and the more broad your diagnostic abilities are, the more you can see, well, in actual fact, there isn't anything else that would better explain this condition. And I'll give you some differential diagnoses in a little while. As I was saying just before, there's these slightly different clinical and research diagnostic criteria that have got different sensitivities and specificities. When we're talking about the sensory signs, the sort of things that we're looking for are a hyperesthesia or an increased sense of touch. Allodynia, which is when light touch or something that we usually wouldn't associate with pain becomes painful. We're looking for the signs that there would be a hyperalgesia to pinprick, so a heightened painful response to pinprick. So we're not looking at sharp blunt discrimination, we're looking at a heightened painful response to pinprick. And also that there's allodynia demonstrated with light touch from a tissue or from a filament or from some cotton wool. Also pain described when there's joint movement as well. The next thing are the vasomotor signs, and the main things that we're looking for here are a difference in skin temperature from one side of the body to the other, and usually this is accompanied by a skin colour change or an asymmetry in skin colour. So it could be that one side of the body looks red or purple or blue compared to the other side, and this is really talking about the foot or the hand, sometimes the knee, or less frequently the elbow. In terms of the pseudomotor or edema signs, we're looking for either edema, a change in sweating, or an asymmetry in sweating or dryness in one limb compared to the other. And the motor or trophic signs that we're looking at are decreased range of movement, some other motor dysfunction like a weakness, a tremor, or a form of dystonia that you sometimes see in some CRPS patients. This isn't so common, but in some of the more severe cases you'll see that. Trophic changes tend to occur later on following the onset of CRPS, and here we're looking for a change in hair, so often thickened, darker hair, but sometimes over time this goes to having no hair in the area at all. Nails that tend to be thickened and ridged, and skin that becomes quite fragile over time. In terms of the pathophysiology of CRPS, it's really quite an interesting and so far not totally known concept. There's a couple, this paper that I've put up on the screen at the moment is a really great paper that really reviews most of the current concepts regarding the pathophysiology. We know that there's actually some form of a neurogenic inflammation occurring in CRPS. And in the past, people thought that there was actually an increased sympathetic outflow, but in fact, we know that there's a reduction in sympathetic outflow in CRPS. However, the way in which the body responds to any sort of sympathetic activity tends to be exaggerated at some points in time. We know that there's nociceptive sensitization and that this happens in the central peripheral nervous system, but also that there's really reduced endogenous pain control. So a lot of those descending pain mechanisms aren't working as well as they should be. There's vasomotor dysfunction, so you get problems within the endothelium, and we know that there's changes in the periphery in terms of what cytokines and chemokines are around. And finally, the last major concept in the pathophysiology is around maladaptive neuroplasticity. So we know that there's cortical changes as well as being signs of neural degeneration in the C and A delta fibres, which are usual pain fibres in the periphery. And I think this concept just leads us very nicely into what Flavia is going to present. So I'll hand over to Flavia now, and I'll be talking to you a bit later. Thanks, Flavia.
Thank you, Anne. Good evening, everyone. This evening I'll be presenting some findings from our group and others on neuroimaging in complex regional pain syndrome. What I'll start off with is Anne's covered it beautifully, but complex regional pain syndrome is characterised not just by pain, but by numerous other signs and symptoms in numerous categories. It's debilitating, it's persistent, usually affects the upper limb, and it seems that about 5% of wrist fractures will go on to develop CRPS. But I've added a bit of a question mark here because a real lack of longitudinal or prospective studies means that we're not quite sure on these numbers. Why do we look to the brain in CRPS? Well, firstly, not to sound defeatist, but I'm sure I don't need to tell the clinicians among us that there is a general lack of success often with peripherally targeted treatments. These people often don't get better. So that's one reason that we looked to the brain in the treatment of this disorder or understanding it. Another is this key definition of pain as being very different to nociception. Nociception or tissue damage or injury is neither necessary nor sufficient for pain to ensue, and so that we must be looking, must look elsewhere, that is the brain, for the processing of nociceptive messages from the periphery and what leads to construction of pain as an output. And finally, there are interesting perceptual phenomena that CRPS patients display, and they really implicate the role of the brain in this disorder. So before we get into those perceptions, there's a few signs and symptoms that look a bit strange as well. You may have noticed that pain and other signs and symptoms spread in a non-dermatomal pattern, and they can mirror to the other limb or to an upper limb to a lower limb, for instance. And again, this relationship between injury and pain, particularly as time persists, just becomes more and more tenuous. In terms of perceptions, CRPS patients have been known to report additional sensations in another site when their affected hand is stimulated over the fingers, so mislocalization of tactile stimulation. They've got poor tactile acuity or two-point discrimination. And then they also report distortions in or problems in the mental image that they conjure of that affected limb. And an interesting study done a few years ago now delivered pairs of vibrotactile stimulation to the hands of CRPS patients. So they stimulated the affected hand and the healthy hand, and the participants were asked which hand had been stimulated first. Now, what was found on average was that CRPS patients prioritized tactile information delivered to their healthy hand. On average, the affected hand had to be touched a quarter of a second before the healthy one in order for these patients to perceive that they'd been touched at the same time. And this error in judgment related to the coolness or how cold that limb was as well, and also to how much they perceived ownership over that limb. Funnily enough, when they crossed their arms over the midline, this effect was reversed. They then prioritized information from the affected hand. So it's not just the affected arm, but perhaps it's the affected side of space or the side of space that the affected arm usually resides in that may be the problem. Furthermore, shifting the lateral field with prism glasses and things like that, shifting the midline changes these results. Again, the skin temperature and these biases in processing seem dependent on perceived body midline, not the actual midline. So the brain seems a pretty good place to look in this disorder. And it seems something is awry with the way the body is presented in the brain, represented in the brain in pain. Now, a definition of pain as a subjective experience underlines that pain is inextricably linked to the state of our own body, and pain always has reference to an anatomical location. Now, our physical body is represented many times throughout the brain, but the most precise representation of our body is in S1, or the primary somatosensory cortex, which is shown here in blue. And it's here that receptive areas for the sensation of touch are organized into a somatotopic map of the body's surface. So you can see the representation of the face here and the hand next door. Together they take up roughly half of the homunculus. And the representation of the thumb here and the little finger up here form the boundaries of the representations of the 5 fingers. Now, what you would see if you were to turn to the literature in CRPS on cortical reorganization or representation of the body would be, sorry, there's the hand. What you would see if you were to turn to the literature would be a study such as this one. What this group has done is stimulated the 1st and 5th digit in the CRPS affected hand and the 1st and the 5th digit in the healthy hand. as shown contralaterally here in S1. And what this group found more than 10 years ago was that the CRPS-affected hand had shrunk. It was half the distance between the activation from stimulating digit 1 and 5 on the affected hand as it was with the healthy hand. And this arguably has led to cortically targeted treatments, things like mirror boxes, influencing someone's perception of the limb and thereby their pain levels. Now, we wanted to know more about this, so we conducted a systematic review. We wanted to know if other studies had found results like that one. We gathered and extracted data from all the studies out there that we could find that had investigated this question of this shrinkage or the size of the hand in S1 and CRPS. And importantly, we also appraised the studies for their quality or risk of bias. What we did find was consistent evidence of a smaller representation of the CRPS-affected hand, much like that study I just showed you there. So, put simply, if down the middle here is the 0 line of difference, here are the studies listed, and this big diamond here to the left just indicates that the 4 studies we found did indeed report on a smaller CRPS hand than healthy hand, because they're all on this side of the line. And furthermore, 2 of those studies recruited healthy controls. So in comparing the CRPS affected hand with that of healthy controls, again, the diamond, the pooled result of the 2 studies, falls over here, indicating that the CRPS affected hand was smaller in S1 than hands of controls. Now, these were all MEG and EEG studies. So there is consistent evidence of a shrunken or a smaller size of the hand in S1 in the CRPS-affected hand, but we were surprised with the limited number of papers we came across. We thought there was more of a general consensus than this. There was only a total of 33 patients. We did find issues regarding quality of these studies, namely lack of blinding in the neuro-imaging analysis. None of them used fMRI, and that has the most superior spatial resolution, which is important for a question like this. And as I said, only 2 of those studies compared the CRPS-affected hand with controls as opposed to just comparing it with the healthy hand in the patients. So what we did was embarked on our own study to investigate this question. And we wanted to investigate the size of the representation of the CRPS-affected hand in S1 using fMRI. And our hypothesis was that we would find similar results to those studies that preceded ours, and we would find a smaller representation of the affected hand than the healthy or unaffected hand in S1, and it would be smaller than the hands of healthy pain-free controls representation in S1. We recruited 17 participants with clinically diagnosed CRPS. So we trust that the physios or the pain specialists that sent us the patients had used those stringent criteria that Anne discussed earlier. We also had 17 healthy controls. These people attended 1 testing session at Neuroscience Research Australia in Sydney, and there's the MRI shown there. We also did an independent assessment and diagnosis of their CRPS in order to see if they did satisfy the research criteria for our own interest. And we gave them several questionnaires on function, movement, mood as well. Now, the fMRI was at 3 Tesla with 32 channel head coil. We delivered, by way of these 2 stimulators here, the people put their thumb here and their 5th digit or their pinky here, and they received vibrotactile stimulation for 20 seconds on their thumb and 20 seconds on their pinky finger, and this was in a randomized order. And we did a 15-minute session on the right hand and then a 15-minute session on the left hand. And at the same time as these 2 functional sessions, we also gathered a structural scan so that then we could co-register the activation we saw in S1 with that hand stimulation with their own structural images, their own T1 scans. Now, I'm not going to go into the depths of data analysis, but there was a couple of things about our analysis that are important and I just want to touch on. The way we did it was we found the highest activation, so basically the biggest blob of activity with our statistical analysis, within a predefined area of S1. So using previous work that has mapped where the thumb and the pinky are in that homunculus, using their coordinates and adding a standard deviation or two as well, given the disease we were dealing with. That was the predefined area of S1 that we worked on. And what we did was found the blob of activation that resulted from stimulation of digit 1 and the same that resulted from stimulation of digit 5, and then mapped the distance in X, Y, and Z space between these to give us a measure of hand representation size, much like that image I showed you at the beginning of the talk. Now, what's important here is that this was blinded. We made sure that the person who conducted these calculations was not aware of whether they were looking at a patient's brain or a control's brain, and they were not aware of whether they were looking at an affected hand representation or a healthy hand representation, because unblinded analyses do lead to inflated effect sizes, not for want of not trying, but it was something we wanted to rule out in this examination. What did we find? First of all, and I hope you can see it on your slide there, is we did indeed find, as other studies have in the past, that the affected hand was smaller in its representation in S1 than the healthy hand. Now, I'll point out this is a representative CRPS patient, but the distances that were calculated between digit 1 and 5 were indeed representative of the distances of the group. So this is a representative patient. We've got a shrunken or a smaller affected hand in S1 than we do unaffected. When we bring in the comparison with controls, however, this is where we had a bit of a surprise. Again, this is a representative patient, a representative control, I should say. What we found was when we compared the affected hand with either of these hands in controls, there was no statistically significant difference. What we instead found was evidence that this healthy hand, or the unaffected hand, was bigger than these two, and statistically so than the non-dominant hemisphere in controls. It's also worth pointing out that there was a statistically significant difference between the dominant and non-dominant hand representation in the healthy control group. So we've got evidence of a bigger healthy hand than either hand of controls. Again, this was just the representative, so let's just go to the group data. Plotted here is the difference between affected and unaffected hand in CRPS patients and dominant and non-dominant hand in controls. So again, there's a statistically significant difference between hands in patients and between hands in controls. And what comes out is that this healthy hand in CRPS is bigger than that of controls, statistically so than the non-dominant hand in controls. So the first thing we wanted to do here was check, is this something to do with dominance and not something to do with the disease? Because if we've got this statistically significant difference between hands in controls, just based on the fact of one hand is used more than the other, that's something we wanted to check. So what we did was removed the minority of patients in whom CRPS did their non-dominant hand. So we did a sensitivity analysis and just compared CRPS of the dominant hand with controls. And basically, all you need to sort of get from this image is that the general pattern remained. That is, we still had this resounding effect of the healthy hand being larger than hands of controls. This did not show a difference between, the affected hand did not show that difference with controls. Now, we did not find a statistically significant or large correlation between representation of the CRPS affected hand and pain intensity, nor did we find a relationship between the S1 representation and pain duration. And this interested us as well. So the unaffected hand, or the healthy hand, appears to be larger in its representation, as opposed to the CRPS affected hand being smaller in its representation when we bring in that comparison with healthy controls, and that's important. These results appear independent of dominance, again important, given that we did find a difference in the representation of the hands in people who did not have CRPS, purely as a result of dominance, but it's good to know that ours does have something to do with the disorder, not just hand dominance. Seems not to be related to pain, that is pain duration, nor pain intensity. And it's important here to note that our results don't necessarily conflict with the existing literature. As I pointed out, there are a few studies who have actually investigated this question. We were the first to use fMRI to investigate the question, but most importantly, only 2 studies had presented healthy control data in the past. So what I think we'd been doing as a community until now was comparing hemispheres in CRPS patients, and indeed we do find that shrunken CRPS affected hand in S1. But when we bring in the controls as a comparison, that's when we can see that our results are slightly different. Now, what might be happening here? I think the most intuitively sensible mechanism by which this is occurring, by which this healthy hand seems to be bigger in S1, is compensatory use. Perhaps people are using it more because of the disease. And we've got data from animals and humans for many years now on use-dependent plasticity. You know, that the plasticity of the nervous system in response to use and function, it adapts according to need. So that's the next question for us. Is the extent of this S1 apparent enlargement of the healthy hand associated with increased or evidence of compensatory use in response to the disorder? Now, this is where hindsight is a wonderful thing, because with our investigation, we didn't collect a lot of data on the use of the healthy hand. We're more interested in the CRPS affected hand. I think we can be forgiven for that. Now we need to look into what these people are telling us about the use of their healthy hand. So we're going back through the data and we're inferring compensatory use of the healthy hand. As I said, we don't have a lot of objective measures on it on itself. What we do have is information on their reported use of their CRPS affected hand. We've got information on their overall function, that is using both hands, and we've got information on their overall self-efficacy, that is their belief or their confidence in themselves to achieve desired outcomes despite their pain. So given that information, we're doing this at the moment, infer compensatory or extra or overuse by that healthy hand and see if this can explain some of this apparent enlargement or larger size of the hand in S1. And we also purport that if people have had CRPS for longer, perhaps this S1 apparent enlargement will be to a greater extent. So they're the questions we're looking at. Overall, this study threw up a few questions, which is always a good thing. Less is known about cortical function in CRPS than we expected. Our results did not implicate the representation of the affected hand, let alone imply cortical reorganization. I should have put that in quotation marks, really. It's something that we talk about a lot in CRPS, but our systematic review yielded evidence of, first of all, studies that have looked at representation of the hand in CRPS, but no studies that had looked at anything longitudinally. So it would be a bit of a misnomer to call it reorganization because we don't have it pre and post disorder or pre and post treatment, for instance. So there's that need for longitudinal studies. And I think this really calls for a rethink given our therapies. It certainly doesn't mean we throw them out. It just means I think we need to understand a little bit more about the basic science and the mechanisms behind why some of these treatments do work when they do. So the future work, I would argue, for us as researchers is to investigate more about perceptions rather than just the basic signs and symptoms. So rather than gathering the basic clinical information as we did when we scanned these people, perhaps we need to know more about their two-point discrimination, their own mental representations of their affected hand. And given that study that I talked about earlier where they were crossing their hands over the midline and getting different results, perhaps we need to look at more spatial frames of reference and not purely somatotopic frames of reference. If we didn't find these S1 results we're expecting, perhaps it's more than just the somatotopic representation, the S1 representation we've come to know, and more about how we incorporate the space around us as well, particularly when we have an injury. And it would be really great to have a look further at the neurocorrelates, so the neuro-imaging with treatments. Again, this prospective and longitudinal style of study. So grab an image of representation of the CRPS affected hand and healthy hand and compare that with controls, apply a treatment and then scan again. And only then can we really call things reorganization per se. The other question we've got is, are these changes necessarily maladaptive? They've been come to be known as maladaptive reorganization or maladaptive neuroplasticity. Our study didn't find that clear relationship between pain duration or intensity and and representation, which throws up questions of whether these changes are maladaptive. And I think that the key for us as researchers is to maintain pace with the clinic. I think when a treatment seems to be working with someone, and many of these treatments indeed do work, it's important for us in the basic science to investigate these mechanisms and maintain pace with what's being integrated clinically. And I think that leads me at a great point to bring in Anne, who'll be speaking from a more clinical perspective. I just want to thank the other contributors to the research that I've just presented, and thanks very much for your attention. I'll be taking questions afterwards.
Sorry, Anne, I think you might have your phone on mute.
Hello, is that better? Sorry, everybody, I was muted. Thanks for that, Flavia. So we're going to talk about clinical management, and the first thing I want to do is just to make a couple of points with you, and that is that CRPS is not a homogeneous condition, that it exists, it's perhaps a spectrum or a number of sort of spectrums of a condition, and so not every case is going to look exactly the same. And I also think that CRPS can be acquired from health professionals, and by that I don't mean that it's infectious, but that what I do mean is that we can label someone as having CRPS when they don't really fit the criteria, and that having CRPS as a diagnostic label can actually be quite a negative thing these days, because many of our patients will go online, they'll Google CRPS, and they can come up with some really scary information. And so I think it's really important to be quite certain about the diagnosis before you start telling patients that you think that they might have CRPS. The next thing is that CRPS evolves over time, and so if I'm seeing something that looks like a really acute form of CRPS in the clinic, a year or two later it's not going to look exactly the same, and in actual fact the different signs and symptoms can wax and wane over time, and people can actually go back and forward between different forms of the symptoms. And perhaps one of the most important things to say is that CRPS doesn't exist alone. It usually coexists with other conditions, because we know that there needs to be an inciting event in the first place. And what we usually think about is that there's some sort of musculoskeletal or perhaps neurological factor that has initiated the CRPS, but there can also be other conditions, and this could be vascular. And even though I don't want you to think that psychological or psychiatric symptoms can be the cause of CRPS, because there is absolutely no evidence to suggest that. People can have CRPS and have a psychological or a psychiatric condition. And so it's important to understand that it sits alongside other signs and symptoms, and that often makes, and conditions, and that often makes it quite complex when we're actually trying to tease out the diagnosis. So the way in which I go about my management of patients with CRPS is really about taking a really careful history of what's happened to them, but also around their general health, and looking at the sorts of treatments that they've had and how it is that they actually come to see me. I tend to get two groups of patients: quite acute CRPS that's generated within my hospital, which is a big orthopaedic and trauma hospital, but also those that come quite late down the track after they've been managed by a lot of other clinicians. I do a comprehensive physical examination, and that's going to include all of the signs and symptoms that I'm looking for in using the diagnostic criteria, but I'm also looking at what other things could fit within the differential diagnosis criteria. And after I've examined them, that's not it. I re-examine people on a fairly regular basis, and that might depend on how acute they are, but certainly within every sort of 4 to 6 weeks, I'm really checking in to see how their symptoms and signs are going. And I formulate a management plan that's got a great deal of flexibility around it, because when you first start seeing someone with CRPS, it's often quite difficult to be really certain or really predictive of how things are going to go. And I also find that by the time they come to see me, they've often not met the goals that they've set for themselves in terms of the recovery of their injury, or what other clinicians have told them that they should be achieving. And really we need to be sure that we set goals for our patients that they can actually meet. So when you're thinking about differential diagnosis with CRPS, one of the first things to think about is, has the extent of the primary pathology been appropriately recognised and managed? And I think in this, one particular example of this is that I would say a lot of us see CRPS following a Colles fracture, but sometimes there can be sort of poorly managed or unmanaged conditions that may actually be contributing to another problem in the area. And for example, carpal instability that hasn't been properly diagnosed and managed might be creating carpal tunnel syndrome, some sort of neurocompression. And so you can actually have signs and symptoms coming from that, making the condition look like CRPS or even coexisting alongside the CRPS. So thinking also along similar lines, is there a secondary pathology? So is there some nerve entrapment that's going on? Or perhaps there's something like a thrombosis alongside a fracture that hasn't been managed appropriately. There could be edema causing a compartment syndrome. There's all sorts of things that can coexist with this. And also in terms of the psychological or psychiatric symptoms, one thing to be particularly aware of is the amount of fear avoidance behaviour that people can exhibit when they experience a great deal of pain. Fear avoidance behaviour can actually lead to a syndrome that looks very similar to CRPS, just caused by disuse of a limb. And there's quite a good paper by Perez et al. Published in 2010, the Dutch guidelines regarding CRPS. It's a little bit old now because their papers only covered up to 2005, but these are the sorts of conditions they included under their differential diagnosis. So entrapment syndromes, compartment, thrombosis, disuse, as I've spoken before, but also somebody could be getting a nerve blood vessel type compression at the costoclavicular region. Lymphedema looks, to me, it looks quite different to CRPS, but at the same time there is no reason why they can't coexist. Infection can also look quite similar to CRPS, although you tend to get some blood markers that aren't present in CRPS with infection. Conversion disorder can also be that the disuse or non-use of a limb that can accompany conversion disorder can mean that someone presents with a lot of the signs and symptoms. And forms of self-harm, such as applying a tourniquet to a limb, can also present looking like CRPS. So in terms of what we're doing at the Austin, we look at the types of goals that the team would set. And here we have a range of therapy. So we have occupational therapy, we have physiotherapy, psychology, and our pain medicine colleagues who are really looking at the person in terms of prescribing medication and maybe looking at some sort of interventional therapy. And the first thing that we're really looking at doing is engaging with the person and developing a really good, conducive clinical relationship with them, because many people who have CRPS have had quite a bad time with other clinicians before they come to see us. And it's really important that they gain our trust before we can really go further with them. Now, we are actually keen to reduce pain as much as we possibly can. And that doesn't mean that we can eliminate all pain, but it's a reasonable goal of treatment that we're going to reduce pain to an acceptable level. We're working also on how the person copes with their condition and their acceptance of the condition as well, particularly when it's looking like being a long-term outcome for them. And then importantly, activity and participation restoration. So really along a functional restoration or rehabilitation model. And I have down there, as you can see, do no harm. And part of this is, again, just harking back to what I was saying about being really careful that you don't bandy about the diagnosis of complex regional pain syndrome, because that in itself can be a nocebo. It can actually have a negative effect on somebody, because it can make them feel that they have a very serious condition, one that's not likely to get better, one that may deteriorate over time. And for the very vast majority of people with CRPS, that is not actually correct. Most CRPS resolves in the first 12 months. However, when we're involved in seeing people over the longer term, of course, we start to see more and more people that have much longer term CRPS. But when I see a patient with acute CRPS, generally I expect that it will resolve. Not necessarily completely, but maybe 80 to 90%. So here is a bit of a flow chart as to what we'll be looking at Austin Health. So in terms of engagement with the patient, we're really looking at assessing them fully, and that might take a couple of sessions, and reintroducing them to touch, so that many people, because of their allodynia, don't like to be touched, and we need to get them used to either touching their limb themselves or allowing us to do that. When it comes to the activity component, it's very much graded, and in terms of graded, I mean in terms of difficulty, but also in terms of a graded exposure approach. So we don't weigh in and do the most fearful tasks with somebody first. We start with things that they're most likely to be able to do easily, but also that aren't likely to generate a great deal of fear in them. But these activities are progressive, so we keep slowly but surely pumping them up over time. And when we're looking at the participation component of this, it's really looking at what their life roles are. If they're a parent, if they're a carer for somebody, if they're working, and also looking at regaining health. Because with any long-term pain-related problem, anything that's really affecting our ability to be active in our life, there are a number of health conditions that go with that. And also when you think about sorts of medications and other interventions that we use with people with CRPS and people with severe pain, there can be really severe downstream health problems from that. And at the end of this, there really does have to be a period of disengagement where we decide that the person is no longer a patient, and I think that that really frees them. They may not be 100% better, but it frees them with everything that comes with being a patient and having to attend healthcare clinicians. And the jury is still out really about whether we say goodbye or see you later. For some patients it is goodbye, but for some people we just need to keep in contact in a sort of a low intensity way over a longer period of time. And that might be by seeing them every 2 to 3 months, by having email communication and occasional phone call. It's not particularly intensive. And over time what we find is that people tend to be able to look after themselves. So in terms of the engagement component, as I was speaking before, it's really about developing an effective therapeutic alliance with the person. And in all of our pain work, it's really about us working together. It's not about me being the boss and telling them everything that they need to do. It's about getting somebody to engage as much as they possibly can. And perhaps that's also going to slowly ramp up over time. Assessing what their motivations and fears are so that you've got a really good understanding of where they're trying to go with this, and start setting some short-term goals that you know that they're going to be able to achieve. Now, these goals might be much, much smaller than what you would usually anticipate for somebody who's had a Colles fracture or similar, and also might be a lot smaller than what the patient's expectations for themselves as well. But you need to set expectations, and usually what you're doing is resetting expectations. And so many of our patients, when they come out of a plaster, think that the day the plaster comes off, they're back to normal. Even if without any CRPS, they can think that. In CRPS, I find that the time to actually recover or improve can take 3 or more times longer than with just a fracture without CRPS. And I give people a lot of explanation and education around CRPS. And this will be verbal, written. I give them a list of websites I would like them to go to. And I find that if you give your patients websites to go to and give them a little bit of a warning about some of the information that's online that's really inappropriate, if you send them to the right websites, those websites will send them on to another good website, and that way you can stay away from some of the horrific websites that are available. And any of our education messaging gets repeated by our team. So we work really hard in saying the same thing in a slightly different way so that people hear it over and over again, because often people are stressed when they come to see us, and particularly if they've got a lot of pain or if they're on opioid medication, they may not be able to take in all the messages that we're giving them at the time. And then the last thing that I do here is that I write a letter. And I don't write the letter back to the referrer, I actually write it back to the patient. And in this letter we go through what it is that they've told me, what I assessed in them, pretty much everything that you would send in a letter back to a specialist or a GP, but I address it to the patient. And in there I put everything that I usually would, so an appraisal and a plan, and I invite the patient to contact me regarding this, and the patient then sort of has ownership of their own letter and they can decide who that goes to. And I might send it to the GP or the specialist, but I ask the patient first before I do this. Sometimes I've got things to say to people that aren't necessarily exactly what they want to hear, but can be a little bit hard for them to manage when they first hear it from me. And I find by following it up with a letter, can really help them to sort of sit down later and go through it again, and also read all of the positive things that I've said in the letter and not sort of concentrate on any particular negatives. In terms of an assessment, this is a fairly thorough process. So I do my usual musculoskeletal assessment, and on top of that, a neurological assessment for upper or lower limbs. And then in terms of their pain, I'm really honing in on that and asking quite a lot of questions. I test for allodynia, and I might do that through light touch. I've got some brushes that I use to test for allodynia, and I use a needle to test for hyperalgesia. When it comes to sort of body schema assessment, usually what I'll say to a patient here is, you know, I'll just sit there and relax your limbs, and what I want you to do is to just look into your mind's eye and tell me, what does your mind tell you about the size of your hand, for example? And does that feel like it's the same size as your other hand? And now think about the distance between your hand and your elbow, and does that feel like it's the same length? And for a subgroup of these CRPS patients, what you'll find is that they'll actually tell you that their hand feels larger or smaller, or that they feel as if their hand has sort of moved up towards their elbow. And so you get this sort of real sort of change in their perception of their body. And I also do left-right judgment tests using the software. In fact, I tend to use the app now because I find it to be very easy, and I tend to get my patients to use the app for the graded motor imagery work. So at the end of this assessment, I have a list of all the diagnostic criteria. I'm ticking them off to determine whether they've been met or not, and from there I will actually formulate a problem list. In terms of the graded exposure component of our treatment, this is going to be around touch, temperature, pressure, movement, and each of these things will be graded up slowly. As well as that, any braces and splints and other support garments will be weaned down, okay? Now sometimes for edema control, or because they've had a tendon repair, they need to wear some sort of splint or support. That's okay, but for pretty much every other reason that someone might wear some sort of support, I would like to wean that down. And often that's because by wearing that support, they're actually minimising any form of contact that their limb gets, and we need to return them to that. In terms of graded motor imagery, I think that as much as anything, it really turns the person's attention towards their limb and makes them focus on it a lot more. And so that's, to me, one of the important aspects of GMI. And again, here we're really talking about explanation and education again. In fact, my patients hear a lot. I'm a big educator of my patients. So I would imagine pretty much everybody will know about the graded motor imagery work from Lorimer Moseley. And when I find a deficit in the testing of left-right recognition, or when the person is describing to me body schema problems, that's when I will use graded motor imagery. If I can't find a reason to use it, I don't use it. It's not a panacea for everything, but there are times when it can really be very useful. And we'll work through the components of it, the left-right recognition, imagine movements, moving on to mirror therapy as well. But also within this, I transfer the types of activities into everyday things. So it might be looking at, as you're walking down the street, just saying that's a left hand, that's a right hand, looking in a magazine, that's a left, that's a right, and just generalizing the activity as much as you possibly can. In terms of the activity and movement that I would be doing with people, anything that we're doing really needs to reflect any current pathology that's occurring and perhaps the degree of allodynia that somebody has. Because if somebody's got a really severe allodynia, it can be very hard to actually put your hands on them at all, and movement can be very difficult as well. So physical impairments that I note at assessment, I would generally use self-management strategies with them rather than me putting my hands on the patient and doing any passive treatment. And again, more of that explanation and education. So when you're trying to work through a graded movement program with someone, it might be that in the first instance they're watching you demonstrate the movement, and then you might give them some cues about thinking about doing the movement while they're watching the demonstration. And provided they're comfortable with that, they can then commence the movement. And I would say, and I really feel like this is going back to very, very basic principles in terms of in terms of physiotherapy and rehabilitation, might get them to do the movement bilaterally, particularly that obviously that can be a bit hard for the lower limb, but for the upper limb it's not hard. And get them to watch their limb as it moves and even to speak about it. So I get them to say what they're doing at the same time, because I think that if you can bring sort of sensory feedback in terms of movement, speech, hearing what you're saying, processing that perhaps we're actually more likely to be able to really get these movements working properly in the brain again. And we'll be pacing the movement. So really working on people not to overdo it, but that they start off, we work out a baseline, and then we slowly move up from there. And then we need to generalise the movement as well. So it might start off as something very basic, but it needs to go on to having a functional component. So within the type of activity that we'd be doing on land, these are the range of things that we would be looking at. And I'll just go on now to just talk a little bit about immersion and moving in water. I'm a big fan of using immersion with CRPS. I find it to be a very good environment to get people moving, and the amount of pressure that is exerted by being immersed in water is actually quite significant. It's higher than if you had a pair of TED stockings on, and you can see from the beginning to the end of a session that there is a definite reduction in edema during the time of the immersion. Now, this doesn't necessarily last for a long period of time, but my hypothesis is that it can significantly improve perfusion. And I've had a number of patients that have very significant colour changes while they're in the water, whereby they've gone from having very poorly perfused limbs to having normally perfused limbs towards the end of the session. Buoyancy can be graded, so you can use it with in situations where weight bearing, you want to have reduced weight bearing, and you can use buoyancy to either assist or resist your movement. It's also a very different sensory experience in the water, and you might find that some patients with CRPS have unpleasant sensations while they're getting into the water, but once they're in the water and the part's immersed, it's often a much more pleasant situation. And I think because people have really reduced proprioception while they're in the water, there's also that distorted visual effect. You can't see your limb looking normal while you're in the water, and also there's this different perception of exertion. So it's quite a good way to have people moving with very different feedback. So again, there's lots of methods that you can use in the water to induce activity. There's always barriers to getting good results with our patients, and with CRPS that's no different. If you find that allodynia is a great barrier and you really can't touch the patient or get them to move, then you might need for them to see a pain doctor so that they can commence some sort of chemical desensitization. And there's so many more drugs around that can do that. So, you know, your amitriptyline, your pregabalin and gabapentin fit within that category, but also sympathetic blocks can radically reduce allodynia. I also find that using things like skins, you know, the sports leggings, can help people to deal with their allodynia, although it'll be unpleasant while they get them on. But also having them immersed in thermoneutral water can be a really good remedy for allodynia. If you think that fear of movement and fear of their pain is a major problem, then getting a psychologist to work in with you can be a really important thing. And that's concept as well about starting with the least threatening activity rather than the thing that scares them the most. And the next thing is that if you're uncertain about what you're doing, or you're worried that there's a risk that you're going to make the person worse or have more pain, then you need to really deal with that and to feel comfortable, because pain patients pick up how we're feeling really, really very well. They're very aware of that. I won't talk now about secondary pain and deconditioning, but when you have a limb that's not working properly, there's consequences on other parts of your body, and there's a whole range of techniques that we can use to assist with this. I do avoid using passive therapies when somebody has a chronic condition that they're going to need to be able to manage themselves in the long run. So in terms of participation, there's lots of people that can be really helpful in this regard. And OTs just have a whole set of skills that are different to what physios have and can work really well. I use orthotists and podiatrists when we're ready to get some decent footwear. And when somebody really needs to get back to work, don't forget about occupational physicians. They can work up a really good return to work plan. And also, if they've got a sport that they want to get back to, finding a good coach or an exercise physiologist is really good for this. So in terms of these participation aspects, in terms of, sorry, I'm just reading a little message. Okay. Sorry. Yep, I will. So in terms of barriers to participation, if they're not progressing, then what you really need to do is to think about escalating the sort of treatment that you're doing. And that might mean that you need to have other disciplines involved, that medication might need to increase, that they might need some sort of intervention. They might need to be referred to a multidisciplinary pain management program. If it's that they're having a lot of trouble accepting what's going on for them, then again, psychology can be a really useful thing. Meeting other people with CRPS can be a useful thing as well. If it's a problem with funding, then university clinics like La Trobe offer some really good podiatry options. SWEP can be used for equipment, and also maybe there's something that you can do that actually doesn't cost as much, and certainly that's something we're used to doing in public health. If there's a lack of support for return to work and retraining in the compensable sector, check that their certification actually allows them to start retraining or be involved in a return to work program. They have to be certified as having some degree of capacity in order for this to occur. And if in the compensable situation you're having trouble gaining treatment approval, make sure that what it is that you're asking for really sits well with the clinical framework. And if there's problems and you think, well, my treatment plan does sit with that, then document the communications that you're having with the agent and escalate them as required. There's no problem with doing that. You can look through about the evidence of physiotherapy on the slide set later. There's a reasonable degree of evidence, but the evidence set is incomplete. There's a couple of things that are beginning to emerge into the literature. Be a little bit careful about the pain exposure physical therapy, but you may want to have a read of that. So are we there yet in terms of managing CRPS? I'm sorry, but we're not there yet. We offer a very interdisciplinary, flexible type of management that we'd say is informed by the evidence, but the evidence set is still incomplete. And in terms of our management, we need to consider how chronic the condition is, what the comorbidities are as well, and not treat everybody as if they have an acute CRPS. And I think that the research and evidence that's coming through these days is really going to shape the future management strategies that we have. And so I think it's really a watch this space at this point in time. We've included lots of references for you, which you can have a look at if you're interested in pursuing this further. And I'd like to thank you for joining the conversation tonight, and sorry that we've sort of run right up to time, but we'd be happy to take questions.
And thank you so much for a very comprehensive presentation, as was yours as well, Flavia. Unfortunately, because it's such a big topic and we've covered it so comprehensively, we are actually out of time. For those questions that have been posed tonight, we'll get Flavia and Anne to actually answer them offline and provide their responses to the questions to you, along with the recording of this evening's webinar. Once again, I'd really like to thank Flavia and Anne so much for sort of just such comprehensive presentations. We've certainly used the time well. I'd also like to thank everyone for joining the webinar tonight. And on that note, we will sign off and say good evening to you all. Thank you.
Thank you.
Thank you.
Thanks, Flavia. Thanks, Anne.